Bismillah Rahman Rahim. First of all, I would be thankful to Feroza's laboratories for inviting me and honoring me for this presentation. Diabetes is a disease which is affecting quite a large number of people all over the world and even in Pakistan. And Feroz is one of the pharmaceutical company which has initiated a program with the name of Stop Diabetes. And one of the program which is included in this Stop Diabetes is the Limbs for Life, and this is a healthcare initiative by the Ferozans Laboratories. If I will introduce myself, I am Professor Taj Jamshed, working as Professor of Medicine at Sharif Medical Dental College, Sharif City Hospital, Lahore, and I am also the executive member of Pakistan Society of Internal Medicine. And the module which is related in this program, that is the type of diabetes screening and diagnostic criteria, and especially this is related with the diabetic complication which is affecting the limb and the care of the diabetic limb and diabetic foot. The main objective of this program is to save the limbs because the limbs are life. And you know, in our daily life, we have to socialize, we have to go out, and we have to earn for the family. And so this is very important. As with the age advances, this becomes more and more important for us to move freely and having the healthy limbs, healthy feet. But as the diabetes number is increasing, the people all over the world are also having the increased number of problems with the feet and the limbs, and at times unfortunately the people have to undergo for the amputations. So this is becoming very important to for us to really create an environment and to take care of our people who are suffering from diabetes, to prevent their limbs, because as I already told you, because the limbs are life. So this is the major objective of this. If we look at this diabetes all over the world, there's a large number of patients, adult patients who are suffering from diabetes. The number is increased to 537 million. And if you look at Pakistan, by the number of patients is ranked as third in the number of diabetic patients. And the other thing is that 1 in 4 adult is found to be having the diabetes, and 33 million people in Pakistan, they are suffering from diabetes, and the prevalence is around 30%. So you can say every fourth is diabetic. And the other important thing to mention is here is that about 26% of the people, they are not knowing that they are diabetic, they are undiagnosed. So this figure really alarms us. And the IDF is actually ranked the Pakistan as the first place for having the highest comparative diabetes prevalence rate in 2021, which is around 30.8%. And this report, as I already mentioned, has noted that about 26.9% of the adults, they are not knowing that they are diabetic. Pakistan is included in the MENA region, Middle East, North African region, and 73 million adults, they are living with diabetes in this region, and 27 million adults living with diabetes in the MENA region, they are undiagnosed. And the other alarming factor is that diabetes is responsible for 7,96,000 deaths in this region. If we look at the effect of diabetes on the foot and the limbs, so diabetic foot ulcers, it's found to be more than 50% of the people of diabetes, they are suffering from this problem, and there is always an increased risk of having this ulcer, and this is around 12 to 25%. And peripheral vascular disease cases in Pakistan, they are noted to have there around 6.6%, and peripheral neuropathy is affecting around 26%. And globally, it is seen that the prevalence of diabetic foot ulcer is around 30%. If you look at the type 2 diabetes, I will not go into the detail, We know that diabetes is a metabolic disease, and this metabolic disease means that the major problem, that is the hyperglycemia, and this hyperglycemia is either resulting from the total insulin deficiency, or there may be decreased insulin secretion along with the other factors like the insulin resistance. And this hyperglycemia has the effect on all over the body, and obviously there may be long-term damage, there may be dysfunction and failure of different organs, and especially the eyes, the kidneys, the nerves and the blood vessels. All these are very important organs. If we look at the classification, you already know since long time that the type 1 diabetics are those diabetics in which the beta cells are totally gone. There is no insulin reserves and no insulin production. So they only need insulin. But the type 2 diabetic patients, these are the patients, and most of the patients, about 9 out of 10 patients of diabetes, they are suffering from type 2 diabetes. And this is mainly because of the progressive insulin secretory defect, and along with that there is insulin resistance. And another classification, that is the gestational diabetes, which is obviously present in the females during pregnancy, and then few of the cases may be suffering from genetic defects of the beta cells, or insulin actions, or maybe exocrine pancreatic function, for example like cystic fibrosis, and even the hormonal problems like the hyperthyroidism, like the Cushing syndrome, they may be having the diabetes. And similarly, some of the drugs which are used to treat the HIV and AIDS, they can cause the diabetes. And this is a long term, since long this is known, that how to diagnose a patient with diabetes. A classical symptom like polyuria, polydipsia, polyphagia is present. So in these patients, if these typical symptoms are present, even a single value which is mentioned here, patient may be having the label, may be labeled as diabetes. But at least two figures must be do at two times the blood sugars must be checked to really label a patient with diabetes. So what are the normal values? If we look at the A1C, it should be below 5.7, and the fasting blood sugar should be 99 milligram per deciliter or below, and the glucose tolerance test and the random 2-hour postprandial blood sugar should be 140 milligram per deciliter or below. But if the values goes up, the stage comes which is called as pre-diabetes. In the pre-diabetes, HbA1c value is noted to be 5.7 to 6.4, and the fasting is between 100 to 125, and the random glucose tolerance test value is between 140 to 199. And if the values goes above these values, so these patients are labeled as diabetes with A1C 6.5% or more, fasting 126 milligram per deciliter or more, and obviously the random sugar is 200 milligram per deciliter or more. So if these values are there, so these patients are labeled as diabetics. But there are certain key takeaways from the American Diabetic Association 2022 Standards of Care updates. So the first one is that whenever you are determining for the first line therapy, the comorbidities should be considered in these patients, like the hypertension, like the hyperlipidemia, like the complications of diabetes, like nephropathy, the coronary artery disease. And so these must always be considered when we going to start any medication or any pharmacotherapy. The second important thing, all adults should be screened for diabetes beginning at the age of 35. Before this figure was higher, but now they have said that even at the age of 35 and above, these people, these adults must be screened for diabetes. And then obviously the woman with risk factors should be screened for diabetes within 15 weeks of pregnancy. Diabetes, as I already told you, this is a metabolic disease, can affect any part of the body from the head to toe, from the right hand to the left hand, from the skin to the inner organs. So these complications can be divided either in the form of microvascular complications or in the form of macrovascular complications. In the microvascular complications, the main organs which may be affected are the eyes, the kidneys and the nerves. So in the eyes, patient may be having a retinopathy or early formation of the cataracts may be there, maybe glaucoma, and these become more prominent when the patient is also having the other comorbid condition. The most common associated is the hypertension. Similarly, in the kidneys, patient may be having the nephropathy, and this may lead to the chronic kidney disease. And again, here high blood pressure and hyperlipidemia, they can worsen the condition more rapidly than the people who are not having the hypertension. Similarly, in the neuropathy, actually the hyperglycemia is damaging the peripheral nerves, and these patients may be having the pain and the numbness and the tinglings. And obviously, if there is numbness, a patient may be having a wound on the feet which may be undetected at times and maybe get infected and may lead to the gangrene. In the macrovascular complications, the major organs which may be affected, the brain, the heart, and the extremities in the brain, patient may be having stroke in the form of ischemic stroke, or even long-term damage in the form of cognitive impairment may be there. And in the heart, patient may be having coronary artery disease, or even the diabetic cardiomyopathy may be there. In the extremities, peripheral vascular disease, which usually results from the narrowing of the blood vessels, and this increases the risk of reduced or lack of blood flow in the legs is there. And patient may be having the foot ulcers, and again this may, along with neuropathy or maybe alone, can lead to the formation of the ulcers and even the gangrene. So if we look at the management of diabetes, you can remember this synonym diabetes. As a basic, three basic steps are needed. One is the obviously the diet and diet modifications. The second one is the physical activity, improving the physical activity, and the third one obviously the anti-diabetic drugs. Depending upon the patient's stage of the disease and the complications of the disease and the need of the patient, we may start with the oral drugs, and if needed we can go to the other injectable like in the form of insulins. But too easy to remember this synonym, like the first D is for the diet. About 50 to 60% of the diet should be having carbohydrates, and especially in the form of fibrous carbohydrates containing fibers. 25 to 35% of the fats should be there, and 15 to 20% in the form of proteins. I for the insulin management, and A for the anti-diabetic agents. There are many anti-diabetic agents which can be used according to the condition. And then blood sugar monitoring stands for B, E for exercise, T for transplant of pancreas, and then ensuring the adequate food intake in this patient. Very important. People think of that they will stop taking adequate food and they will control diabetes, which is actually harming the patient. And then obviously scrupulous foot care, very important. As I already told you, our feet are very important part of our body, and this is especially directly related with the our social life, our the economical and financial life. So this is very. If we look at the diabetic foot, we already know that what is the anatomical structure of the diabetes. I'll not go into the details, and the picture here which is shown, that is showing the different parts of the bones and which are there in the foot. But what is happening in diabetes? In diabetes, there may be three factors which can lead to the diabetic foot problem in the form of either the ulceration, or and then obviously may progress to the amputation. The one is which is the direct, that is the trauma, and the other factors which are especially important in diabetic, that is the neuropathy and the vascular disease. In the neuropathy, patient may be suffering from the motor neuropathy, the sensory neuropathy, the autonomic neuropathy. In the motor neuropathy, patient start developing the weakness and atrophy, which may lead to the deformity. There may be abdominal stress, and Cause of the high plantar pressures, there may be callus formation, and patient ultimately may have tendency to develop the Charcot's joint, and the structural deformities and chiroarthropathy may lead to diabetic foot ulceration. Similarly, there may be loss of protective sensation in the sensory involvement, and even the autonomic involvement may lead to the anhydrosis of the skin, and skin may become more dry. There may be decreased sympathetic tone, which is actually related to the altered blood flow regulations in the feet. And these all neuropathic problems may lead to the Charcot's joint and even diabetic foot ulceration. On the other hand, vascular disease, as we already know, may be in the form of microvascular or macrovascular. Microvascular are usually affecting the nerves and leading to neuropathy, and similarly the macrovascular, the big vessels like the popliteal, like the femoral, or maybe the dorsal SPD and the other arteries may be occluded, leading to narrowing and maybe ischemia, and patient may have the decreased nutrient capillary blood flow to the foot or the limb and lead to ischemia, and this ischemia may directly lead to the either the gangrene and resulting in amputation, or may be affecting the foot along with the other problems like the anemia and nutritional deficiency. So because of the poor circulation, there are more chances of infection, and the poor response to infection is noted in these patients. These are the one of few of the initial complications of diabetic foot in the form of hammer toe. You can see here the claw toe, and the flat feet may be there. The high arch palate may come up, and patient may be having the pain in the metatarsal areas, and this bunion toe can be seen here. You can see here, this is bunion toe, which can be easily seen here, and the big toe is actually deviated towards the lateral side. If we look at these diabetic foot problems, so normally the people who are coming to us, they are having the neuroischemic problems, and sometime patient only may be having the ischemic problems, or maybe having only the neuropathic, but most of the people, they have the neuroischemic. Neuropathies are there, and along with that the ischemia and the peripheral vascular disease or the microvascular disease is there. So this is a combination of two. And neuropathy, if you look at that, this is a double-edged sword. So on one side, patient may be having the effect from the diabetes directly in the form of hyperglycemia, or maybe the other factors like the dyslipidemia and this esterified fatty acid dysmetabolism is there. So these all metabolic changes which occur in the feet because of diabetes may lead to neuropathy, and patient may be having the decreased sensitivity in the feet. Patient may be having the electrical like pain, like current, and even patient complain of burning feet and pain, especially in the night time, and tingling sensation as the ants are creeping on the foot, and muscle weakness may be there, and patient, the other major problem, that is. So how this neuropathy is assessed? There is a monofilament test, which is the Semes Winston monofilament test. 10 gram filament, which is flexible, is used to assess, and this is actually assessed on the sole of the foot, and different areas are actually checked, and then the score is made to find out whether the patient has the feeling of these monofilament or not. So accordingly, this monofilament test is one of the important tests, clinical tests. In the clinic, we should use this to assess the development of the neuropathy. In relation to the ulcers, if we see that there are certain risk factors for ulceration, like the general risk factors like the uncontrolled diabetes mellitus, duration of diabetes. If it is more prolonged, so more chance of developing the ulcers. Similarly, the presence of peripheral vascular disease. If the blindness or visual loss is there, it means that patient Visual loss mean the patient cannot see, especially in the night time, and patient may have trauma to the feet. Because of that, more trauma and more damage. Similarly, the chronic renal disease and old age. But there are certain local factors which may be there and which make the patients more prone to develop the ulcers, like the peripheral neuropathy, the structural foot deformities, trauma and improperly fitted shoes, callus formation, and the history of prior ulcer or amputation. There are also, if the patients are having the prolonged elevated pressures, and if the joint is not moving smoothly. So limited joint mobility is one of the risk factor for development of the these ulcers are classified according to the one of the very famous system, a classification system, which is called as Sinbad system. And in this, S for side, either this is forefoot or midfoot or hindfoot. So we give a score 0 or 1 according to, as you can see in this chart, in classification chart. So we give either 0 or 1 according to the involvement of the foot. If ischemia, if there is a pedal blood flow is intact, at least one papal pulse is there, so 0 score. If there is clinical evidence of reduced pedal flow, the score is 1. Similarly, the neuropathy, if the sensations are intact, no score. If sensations are lost, 1. Similarly, bacterial infection if present, then given 1. If the area is more than 1 centimeter square, again the score is 1. If the depth of the ulcer is confined to the skin and the subcutaneous tissue, this is given 0, and ulcer reaching the muscle, tendon or deeper, this is 1. So the total score is 6. So if the score is coming up to 3, this is called as non-complicated diabetic foot ulcer, and there is no infection or maybe mild infection. But if the score has gone to 4 to 5, usually these patients are having the complicated diabetic foot ulcers with moderate infection. But obviously if the score is 6, this is called as severe complicated diabetic foot ulcers and with severe infection. These diabetic foot infections may not only affecting the skin, this may lead to the even involvement of the bones, resulting in the osteomyelitis. And it is seen that osteomyelitis can affect any bone, but most frequently the forefoot. Mean 90% of cases they have the forefoot bone involvement, which is followed by 5% of the midfoot and 5% in the hindfoot. So mostly the forefoot bones are affected, which may have the osteomyelitis. And on the other hand, amputation is risk is higher, significantly higher for hindfoot. About 50%, half of the patient may be having the hindfoot involvement and may lead to the risk of amputation than the midfoot and the forefoot. And this diabetic foot infection and osteomyelitis is graded according to the involvement and the skin and the bones. And if there is no open lesion, this is grade 0. But if the patient is developed the gangrene of the entire foot, this is grade 5, and in between you can see grade 1, 2, 3 and 4. And this is one of the commonly mismanaged, these cases are commonly mismanaged and may lead to the amputation, because callus formation has 11-fold increased risk for the foot ulceration and foot infection, and diabetic foot ulcers not resolving for more than 8 weeks has these 15 to 20% chances of bone infection and foot gangrene. So this is important to note that if the patient, as the time passes, the chances of going to have the amputation becomes. On the other hand, if we look at the peripheral arterial disease, about 50% of patient with critical limb ischemia, the advanced stage of peripheral vascular disease, peripheral arterial disease, is associated with low extremity amputation and significant mortality. They also have the diabetes, and they are affected more than the people who are not diabetic. This is the picture which is actually showing the importance of revascularization And you can see here on the left side the picture with the patient who was having the popliteal occlusion on the right side and developed the gangrene of these 2 to 5 toes. And you can see here the early revascularization were done, and the patient, obviously these were gangrenous toes, so these were removed, so patient has saved the limb. And the other, there is no further extension, but if we don't do the revascularization, this obviously extends upward and may lead to the even the below knee amputation, maybe above knee amputation. We have to go for that. But in non-responder, this is one of the patient not having much of the diabetic foot problems here, only just this some redness is there. And but this patient was late and having the femoral involvement. But this, although the amputation was done, sorry, the revascularization was done in this patient, but with this patient was having the poor outcome. And even you can see there the gangrene is already developed in this patient, and with the involvement of the foot, which is progressing further. So this is very important, at what time you have to go for the revascularization, if done at appropriate time, and with the possibility of the healthy vasculature or low limb vessels, so more chances of response rather than going for the late. What actually this peripheral arterial disease is having the effect on the limbs? Actually, this leads to the, because of the poor peripheral vascular circulation or peripheral arterial disease, patient may be having the decreased aerobic capacity and decreased muscle strength. Because of this, patient usually walk less, and the quality of life is deteriorating. And because of this, the patients started developing the diabetes, developing the increased risk of diabetes, and the obesity chances become more, and there may be chances that the patient will be having the arterial hypertension, maybe dyslipidemia, and this further worsen the problem in the form of decreased oxygen supply to the peripheral parts. And there is an endothelial dysfunction which may lead to ischemia and reperfusion, and there may be increased inflammatory markers and increased free radicals, and then ultimately there may be muscle fiber atrophy, and the altered muscle metabolism is there. And this is a vicious cycle. This continues. This starts from here, from the peripheral arterial disease, and going towards the obesity and decreased supply of the oxygen and affecting the muscles, and this goes on and goes on, and this ultimately leads to the diabetic foot. So 40% of people with peripheral arterial disease, they don't have leg pain. This is also one of the important factor which must be in mind. If you look at the arterial, diabetic and venous ulcerations, how to differentiate whether this patient is having diabetic ulcer, whether the patient is arterial ulcers and venous ulcer, I will not go into the details. I'll just concentrate more on the diabetic ulcers. The patient with diabetes and peripheral neuropathy with the long-term uncontrolled or poorly controlled diabetics, they have the predisposing factors. But in the arterial ulcers, patient may be having only the peripheral vascular disease, maybe diabetes or advanced stage is there. In the venous, there may be valve incompetence and perforating veins, history of deep vein thrombophlebitis and thrombosis, and previous history of ulcers, obesity, and advanced age may be the risk factors. And anatomical location, mostly the arterial ulcers, they are between the toes and tips of the toes or over the phalangeal heads, but in the diabetic ulcer, these are present mostly at the plantar aspect of the foot, over the metatarsal heads or under the heel. But in venous, these are mostly present in the medial lower leg and the ankle on the malleolar areas. And patient in arterial ulcer, they have the thin, shiny, dry skin, hair loss, ankle and foot, and there may be thickening of the toenails, but in diabetic, diminished or absent sensation in the feet, foot deformities, palpable pulses may be there, warm foot, subcutaneous fat atrophy may be there, but in venous, there may be firm edema, dilated superficial veins, and dry thin skin may be there. So wound characteristics in arterial, even the wound margins are quite even with gangrene or necrosis. But in diabetic, even the wound margins are there with the deep wound bed, cellulitis or underlying osteomyelitis may be there, and granular tissue may be present. But in the venous, their margins are irregular, superficial wound is there, and this is ruddy and granular tissue may be seen in this patient. Charcot foot, if we see that, I've already mentioned this is a dilemma really, and this is actually characterized according to the characteristics divided into different stages. And if there is only erythema, edema, and increased temperature to foot is there, this is stage 0 for Charcot foot, and the treatment is only limited weight bearing and close observation. If there is periarticular fractures, joint dislocation, instability, or deformed foot, this is stage 1, which is called as fragmentation stage. Here we need total contact cast and limited weight bearing. If there is reabsorption of the bone debris is there, this is called as coalescence stage, and here we need the total cast, contact cast, which is followed by the Charcot restraint orthotic walkers. And the reparative stage, which is the stable foot, in this stage is there, and the possible surgical intervention is needed for the removal of the bony prominences associated with the ulcer. So at the end, diabetic foot care management include the metabolic or medication management, optimizing the associated medical conditions like control of the diabetes, hyperlipidemia, and hypertension, and obviously the assessment of the foot ulcers and grading the ulcers according to the Prevalence classification, including the perfusion, extent, depth, infection, and sensation. Then debridement as per need. Surgical debridement is especially for the necrotic or unhealthy tissue. The role of antibiotic is always there, and this is basis of the according to the severity of infection, we go for the appropriate antibiotics. And the dressings are performed frequently to have the good wound care and adequately dressed. Offloading, advise the patient with diabetic foot ulcer to wear the appropriate offloading shoes to reduce the plantar pressures, and then the patients must be referred to facilitate for the early multidisciplinary diabetic foot team for the optimal management of diabetic foot ulcers. Education, very important. So education on the foot self-care should be provided to patients with diabetic foot ulcer or risk. So these are the footwear qualities are which for the foot ulcers. What should be there for the feet? What type of characteristic must be there? The first thing is that the shoes must not be either tight or too loose, and should be having the wide toe box for the free movement of the toes. And the inside of the shoes should be at least 1 to 2 centimeter longer than the foot, and the internal width should equal to the width of the widest part of the foot, and height should allow enough room for for all the toes. And shoes should not be made of soft leather. Shoes should be made of soft leather because they can stretch, and we must be choosing a cushioned sole over a thin leather sole because of the shock absorption quality. Tough but light-weight outer soles absorb the plantar pressures and limit the motion of painful joints. Footwear requires the lace or velcro closures, which will help to address the size and deformities in the foot, and well-padded inner surface protects the foot from injury due to the friction between the foot and the footwear. The footwear should always be purchased in the evening time. This is important because by the evening time, usually because of the day-long walking, there may be some swelling on the feet, and there must be not leading to the tightness of the foot. So these are the different offloading devices for the management of foot ulcers, and in the different form: traditional total contact cast, and similarly roll-on TCC system, removable boot, and crow boot, ortho wedge, post-op shoes. So these are different types of devices which can be used to take care of the feet. So at the end, the foot examination, especially for the people who are preparing for their exams, as in the OSCE exams, diabetic foot examination, the OSCE checklist is almost similar as to the other examinations, and including the introduction, introducing yourself, washing hand, and then obviously explaining to the patient in a brief way about the examination which you need, and then inspect especially the gait, and also set the patient's shoes. Inspect the feet for the asymmetry or deformity, scars or skin changes, ulcers or gangrenes. And assessment should be made for the peripheral pulses, especially the dorsalis pedis and posterior tibial. Capillary fill time is assessed, temperature, touch sensation, including the soft and sharp sensations. Then the vibration sensations are assessed, and ankle jerk flexes should be checked. And the examination is completed by saying thanks to the patient and allowing them to redress. And to complete the examination, you can ask that for the capillary blood glucose measurement, peripheral vascular examination, urine dipstick, or even the fundoscopy. And the evaluation of different parts include the dermatological, musculoskeletal, neurological, and vascular. And dermatological, obviously skin status, sweating, infection, ulcer, callus. In the musculoskeletal, deformity, muscle wasting. In the neurological, as we have discussed, with the 10-gram monofilament test, with the vibration sensation, pinprick, ankle flexes vibration. And vascular assessment include the foot pulses and the ankle brachial index if it is indicated. And at the end, this is the one of the program which is actually arranged by Feroz's pharmaceutical in relation to the stop diabetes care with the limbs for. There are certain questions I'll quickly go through with the answers. 1 in dash adults have diabetes in Pakistan. 1 in 4 is actually. Question 2, dash percent diabetic patients develop diabetic peripheral neuropathy leading to the ulcers. This is 50.9%. In pre-diabetics, A1C ranges from, I think most of the people you know, this is between 5.7% to 6.4%. Trauma, neuropathy, and dash leads towards the diabetic foot problem, vascular disease. Trauma, neuropathy, and vascular disease. Then the question 5, according to Sinbad classification, if category C is there, neuropathy, protective sensation lost, the score will be 1. And then the question 6, this picture, this response, this representation is called as onion toe. About dash percent of the patient with critical limb ischemia, the advanced age of peripheral arterial disease associated with the lower extremity amputation, 50%. Anatomic location of ulcer of the toes or tip of the toes indicates arterial ulcers. If you have to consider the wound age of the fresh wound, what will be the time limitations to observe? This is less than 8 hours. So at the end, I would be thankful to all of you for patiently listening, and I am Professor Taj Jamshed, and on behalf of Feroz's Pharmaceutical with the healthcare initiative, in relation to the stop diabetes and limbs for life. I have had the honor for this presentation. Thank you very much for patient listening.